We are tackling treatment for chronic spontaneous urticaria, also known as CSU. And joining us today is Dr. Gogate. Welcome to The Itch.
Thank you so much for having me.
I'm glad that we're getting to talk to you today. So last episode, we talked about how we diagnose a patient with CSU. And then once the diagnosis is made, how do you go about figuring out what treatment path you're going to take the patient on?
Spontaneous urticarias occur more so just almost randomly, and it's hard to pinpoint what causes them. The first step, I think, in treatment is coming to the understanding that perhaps we won't know what causes the hives and that, in fact, they are just occurring spontaneously, or we used to call it idiopathically, meaning like we don't know basically why that's happening. There are some factors that play into that. So stress, some allergic contributions potentially that will play a role in that. And so the first step, I guess, in talking to a patient who has hives is to kind of understand that aspect of CSU. And then if you start to look into algorithms, the first step, and if you look at the European guidelines, for example, the first step is to use antihistamines. And I will see many non-allergists start with the first generation antihistamines like Benadryl or hydroxyzine. I really caution the use of these medicines, the first generation antihistamines, especially at higher doses, just because they have quite a bit of anticholinergic side effects. So meaning like they penetrate the blood-brain barrier, they can cause sedation, and at higher doses can even have some cardiac effects. So I tend to stick with the second generation's H1 blockers. So these are medicines in the US like sertrazine, fexofenadine, loratadine, levocetirizine are kind of the options. And so the guidelines really suggest these medicines as the first step in treatment. I tend to go with fexofenadine or Allegra as the first choice just because it tends to be non-sedating. There are some individuals that have some sedating side effects from sertrazine. And so as we're going to usually dose up for hives, so I usually start with fexofenadine, 1 tablet twice a day, and then we can actually increase to 4 tablets in a day. So understanding that that's not what the box might say, the over-the-counter, it says 1 tablet every 24 hours. And that's fine for people who have hay fever or allergic rhinitis, nasal congestion, rhinorrhea, sneezing. But it's not really enough antihistamines for patients who have hives. And so it is pretty safe to use, say, Allegra, fexofenadine, or sertrazine 1 pill twice a day. And then depending on how well you're doing, increase to 2 pills twice a day. Sometimes, depending, you can even break it up, do 1 pill 4 times a day or 1 pill 3 times a day, but that becomes hard to do in a busy life. So I tend to just do 2 twice a day. And above the 4 times dose of antihistamines, it's not that it hurts you or has a lot of side effects, but it just doesn't tend to work anymore, more than 4 times the dose of a second generation H1 blocker. So, sertrazine or fexofenadine is what I tend to go with. I have to say for insurance purposes, though, at least in Colorado, I find that we need to add on an H2 blocker. So something like famotidine is an option as well. Truth be told, famotidine or an H2 blocker like Pepcid, which is often used for heartburn, right? But it has some histamine properties, antihistamine properties, so it can be used in urticaria. I don't really think it does too much adding this medicine, but sometimes it's kind of mandated by insurance purposes to add this on in order to get the drug that I think really does have quite a bit of efficacy, which is this medicine called Omalizumab or Xolair.
So, Shaila, you talked about the guidelines. We kind of mentioned the guidelines in the last couple episodes also. So using the guidelines, we know that antihistamines should be tried first. And then once we've used the antihistamines at about 4 times the dose, as you mentioned, then we've hit that marker where we think that antihistamines are going to be beneficial for this disease state. How long do you keep a patient on the antihistamine before you decide that they're not responding to the antihistamine?
So antihistamines will work relatively quickly. What I usually will do is see a patient back and follow up in about a month after we start treatment. If they're having refractory or breakthrough symptoms despite that, I'll see them as quickly as a week or even 2 weeks after the initial visit. More often than not, if they're going to work, they tend to work relatively quickly. So let's say about a month.
Yeah, I agree. That's usually what I do for my patients, and just make sure that they're actually using it regularly and that they're not missing doses to really give it a good trial is super important, because if we have people using them on and off, then they might not be working just because we're getting breakthrough hives merely because they're not using the medication. So if you don't have the medication in your body, it's not going to work. So it's not a cure for the hives, which we always like to mention. It's really blocking the hives from occurring in that moment. And for as long as your body needs that medication in order to block the hives from occurring.
So it sounds like you use antihistamines at a 4 times dose, which is crazy to me because I take one a day. But why antihistamines? Why is that your first go-to medication?
What it basically comes down to is what causes hives in the first place. And urticaria angioedema is really a histamine process. So it comes from these cells called mast cells that our bodies have, and the mast cells will release histamine, which acts on other components of the body, so the skin and the blood vessels and such things. And so what we want to do is use an antihistamine to basically block those responses. And those responses are like itch and hives and swelling, basically.
Okay, so that's what Dr. G means when she says you're not curing the hive, you're just blocking the hive. And like you said, antihistamine blocks the histamine. And so you're blocking the hive from happening. You're not curing the hives. And this is why you have to make sure that you're always taking the medication, because if you're not, the hives can come back.
Correct.
And histamine, we love histamine on this podcast. We've talked about it so much. And I can link a YouTube video where Dr. G gives a really good explanation of the mast cell and uses the comparison to a piñata. So if you're interested in knowing a little bit deeper into mast cell and histamine, check out that link in our show notes.
One thing I wanted to go back to was, so you're talking about antihistamines, and there's many, many different types of antihistamines. You mentioned the first generation and the second generation. And within that second generation category, we have many options. And I just wanted to mention that every allergist has their go-tos for the antihistamine of choice. Then different patients may respond differently to different antihistamines. Do you ever consider changing the second generation antihistamine before considering switching altogether?
Sure. So what you're getting at, Dr. Gupta, is kind of the art of medicine rather than the science of medicine. And as you say, every allergist has their own point of view and perspective on this. I feel between the 3, maybe 4 big ones, so loratadine, levocetirizine, cetirizine, and fexofenadine, that they're equally efficacious. Changing antihistamines, I typically do not recommend. I also like to simplify their medicine profile. So taking fexofenadine in the morning and cetirizine at nighttime, I'll only really go to that if they're having side effects. So if they're feeling sedation from cetirizine at higher doses, I'll have them use that at nighttime, and then fexofenadine in the morning. But generally, if they're not having a significant side effect profile and are tolerating the drugs well, there really isn't a benefit to switching around antihistamines. It just adds to the cost, is my feeling. Now, I know there might be a difference of opinion amongst the allergy community, but generally in terms of effectiveness, it's kind of, they're equal.
I think the reality is that we don't have head-to-head studies that are big enough, robust enough to really give us that information, or even any kind of bench research. Bench research means lab research, which kind of gives us more information about each of these individual antihistamines and if any of them are maybe stronger than the other. And I have found personally that different patients just respond to different antihistamines individually, and certain patients just prefer different antihistamines. But I agree with you that constantly switching them around and trying to do that for too long can just be a cost issue and likely won't result in any major benefit. And then quickly, can we just talk about the side effects? I think we've kind of mentioned one big one, which can be feeling tired or sleepy on some of these medications. But are there any other side effects that we need to be aware of for antihistamines?
Yeah, so I just would like to comment on that last one in regards to what the patient preferences are. I think this comes down to shared decision making. So if a patient has better efficacy with fexofenadine or loratadine, I think we maximize the antihistamines that they have at home, that they bought, frankly, already. The main side effect that I think of with second generation antihistamines, so the Zyrtec class, if you will, is primarily sedation. I feel that some patients, especially living in Colorado, will get dryness of their mouth, dryness of their skin. But in general, because these are cleaner antihistamines than their parent compounds, like the medicines diphenhydramine or hydroxyzine, there tends to be less side effect profiles in general.
Can I just ask about two side effects? I know that personally I've experimented with antihistamines because some give me stomach aches. And I know that I've had conversations with other people where they tell me that certain antihistamines make them gain weight, whereas other ones don't. And this is just like patient stories that I've heard. Can you comment on those two side effects?
Kortney, I think in general, any medicine can cause any side effect in an individual. And I think the important point to that is that you listen to your patients. And if your patients are telling you that they're having hair loss, I've had those comments, or they're gaining weight, or they're feeling overly sedated from one, I think we listen to that and change the antihistamine at that point. So that goes back to Dr. Gupta's previous point that typically we don't change around antihistamines unless you hear from your patient that it's not working and there's reasons for it related to side effects.
Or that they're not taking the medication because of side effects. So,
Right.
Yeah, I absolutely agree. You have to always ask and make sure that there aren't other things that are going on before moving in a different direction in therapy. So then a patient has been put on the antihistamines. They're taking the antihistamines. They're taking them at 4 times the dose, and they're not improving. And we've given them that trial of about a month. They're still continuing to have hives despite taking all of this medication. And then you might have put them on this H2 blocker, which blocks the histamine in a different way, and they're still not responding. From there, that's where the guidelines then recommend considering different types of medications. What do the guidelines recommend next?
If you've seen the patient back in follow-up and they're on the 4 times a day antihistamines and maybe they're on H2 blocker like Pepcid and they're still having breakthrough symptoms, I think the next step is really to assess and see what the patient's quality of life is. Because now the next step in treatment is a little bit more invasive, I think is a good way to say it. Because we're talking about medicines that have a little bit more side effect profile, or they're injection-based medicines. The guidelines really have this very beautiful diagram that has these interconnecting arrows that talks about assessing, acting, and adjusting. And that I think is very patient driven, because there might be some patients who have 1 or 2 hives, or maybe they even have 10 hives, but they're fleeting and they're not really bothersome. And they're okay with being on 4 times a day antihistamines and they're comfortable with that. But then there might be individuals where they have 10 hives and it really does impact the quality of their lives because they're in some client facing career and they're giving speeches and the hives are on their face. So it really comes down to having a honest, heart-to-heart discussion with your patient, spending time with them and understanding where they want to be in terms of their hive control. So assess, adjust, act according to what the quality of life impact is for your patient. And if in fact they find that, well, no, this is really not tolerable, this is impacting their day-to-day activities, then I think about other medicines such as injectables, such as Omalizumab, which is called Xolair. There are other oral medicines like cyclosporine, and to a lesser extent, things like doxepin or Plaquenil or hydroxychloroquine are kind of thoughts. But assuming you have a patient at a 1 month follow-up is having quality of life issues with 4 times a day antihistamines and maybe an H2 blocker, the next step is likely Xolair, which is Omalizumab or an injection medicine.
So Omalizumab, we have talked about Omalizumab on other episodes, but can you just talk a little bit about how it works for patients with chronic spontaneous urticaria?
Xolair, which is the trade name, or Omalizumab, was actually approved for asthma now like 20 years ago. While it was being used for asthma, many asthmatics have hives. Allergists noted actually that their hives got better while they were on omalizumab for asthma. And so this drug completed its FDA trials. So it finished the placebo-controlled phase 1, 2, 3 trials. And what this medicine does is basically provides for about 70% reduction in symptoms by week 12. So that means that if you can quantify the degree of hives by something called an Urticaria UAS score, it basically decreased the severity or changed their UAS 7 score significantly by week 12. And about 67 to 70% of individuals responded with pretty good control of their hives. So really a pretty remarkable drug in terms of treatment for hives. I have to say, prior to Omalizumab being available as an FDA-approved product for hives, many allergists would kind of hit their heads against the wall trying to figure out ways to treat our hive patients, because it basically was antihistamines and then more antihistamines. And then after that, even more antihistamines, because there wasn't really a good option. In terms of why this drug works for hives, I think that the mystery is out there. I don't know if we really know the exact mechanism of action, but what we find is that it tends to work pretty well, actually, for urticaria.
So the UAS7 that you mentioned, I just wanted to go back to that. So that's the Urticaria Activity Score. And it's basically looking at what patients are experiencing over a week. They're asked to kind of rate their symptoms over a week. The higher the score, the worse their symptoms. As the score comes down, that means that they're improving. So I just wanted to quickly mention that. And you can find that, and we'll link that in the show notes in case people want to kind of check their UAS 7 and see where they're at and share it with their doctor. So now the patient has decided through shared decision making that they want to use Omalizumab. So this is an injectable medication, correct? And how often is it given?
The dosing of the medication is 300 milligrams every 4 weeks. So 2 shots once a month or so.
Are those 2 shots something that the patient can do at home, or do they have to go to their doctor's office for them?
I recommend doing this in the office. It can be given at home.
Since the pandemic, actually, a lot of medications got this home indication, thankfully. And with Omalizumab, if the patient and with shared decision-making does decide that they feel comfortable giving themselves a shot at home, they can decide to do that. The only thing is that we haven't gotten into the side effects, but one of the possible complications of using Omalizumab, it can cause anaphylaxis, which is a severe reaction to a medication. And anaphylaxis is essentially where you can have shortness of breath, wheezing, hives, swelling of the face and eyes, and it can lead to something more serious that can be life-threatening. And so because of that, we need to monitor the patient for the first 4 doses of treatment to make sure that they're not a patient that has that reaction to the medication. And if they don't have that reaction, then they can take the medication at home. They will be prescribed an epinephrine device for at home in case they do have that reaction while they're taking it at home. With home dosing versus in-office dosing, really shared decision-making is very important. Some patients just really do not want to do injections at home, and so they choose to come into the office. Other patients may travel for work, they have too many kids at home, they just have too much going on where they can't make it into an office and they feel comfortable giving themselves injections, and so they will opt to take it at home. So really, again, it's not a one size fits all. It's really about what makes sense for you. And then in addition, unfortunately, as Dr. Gogate mentioned, with insurance companies, we sometimes do have to think about what they want. And sometimes they won't approve it for home use, or sometimes they won't approve it for in-office injection. So it really depends on that sometimes too. So what is the age range for this medication?
It is approved for urticaria for patients that are 12 years and older.
And what are the side effects of Omalizumab?
Generally very well tolerated medication. I have seen some rare instances of injection site reactions. Usually that's technique related, or it's like hits the wrong spot in the skin. I would say the main side effect that omalizumab has is this risk of anaphylaxis. So it's a funny thing, a drug that helps so much with hives and has been approved for other indications to treat anaphylaxis can actually cause anaphylaxis itself.
And I just want to mention that that is rare. So it's not common for anaphylaxis to occur on omalizumab, but it is possible. And that's why the FDA has recommended that these precautions be put into place. If the patient tolerates those initial doses in the office, then the patient should be safe to take it at home. But in that rare case that they do still have anaphylaxis, then they have the epinephrine device to treat themselves in that situation.
This is not a cure, right? This is just something that you're taking to block hives. It's not completely wiping out any chance that you're ever going to have hives again. Is that correct?
Correct. So while patients are on this medication, their hives are controlled. Most people with hives have resolution of their symptoms independently within the first year. The whole idea behind this is to get them controlled and comfortable until their hives run their course, basically. So it isn't a cure, but it's a very effective treatment to suppress the hives. So about 90% will have resolution by the first year. And so what I typically will do is once their hives are controlled, maybe after 6 months, start thinking about weaning medications. And this goes back to the assess, act, and adjust, because you don't want to put a patient on a medicine and not think twice about it. Always think about less is more kind of concept.
Okay, so this isn't a lifelong medication. Basically, what you're doing is you're going to put them on it, and then together with the patient, you kind of figure out, is it time to see if your hives have resolved at this point?
Correct. So usually start weaning antihistamines is my initial thought once we have hive control, hive and angioedema. So, for me, they kind of go hand in hand. If at 6 months' time we're seeing improvement and control of hives and angioedema, I first start weaning antihistamines from that 4 times a day dose to perhaps just once a day antihistamines. And then at that point, start decreasing the frequency of omalizumab is my general tactic. So going from 4 weeks to 6 weeks. And then if at 6 weeks, go at 8 weeks. And if we're still well controlled, stop it altogether.
Yeah, and this is really important, and we haven't really talked about this, but those mast cells that I said get twitchy, and also Dr. Gogate, you use the same term. That's what I usually talk about when I talk about the mast cells with chronic spontaneous urticaria. But once they do eventually stop becoming twitchy, and that's the great thing. That doesn't mean that you couldn't get hives again at some point in your life. If you've had chronic spontaneous urticaria at one point, you could have it again. But at some point, they do start becoming less twitchy. And within a year is usually what we see, as Dr. Gogate mentioned. So those are important things to remember. And I think it always makes patients feel better when I let them know that hopefully this will eventually resolve. But in the meantime, we need to keep them comfortable and get them through this episode.
There are other options that are currently available other than omalizumab. Primarily, the one I think about is a medicine called cyclosporine, which in clinical trials has shown to have relatively the same efficacy that omalizumab does in patients with chronic spontaneous urticaria. It is an immunosuppressant drug, so it has a few more side effects and more monitoring that needs to be performed compared to omalizumab. So blood pressure checks, laboratory studies are generally needed more than would be for omalizumab. But for patients who haven't done well with Xolair, who are not controlled with antihistamine, this is really a good option as an alternative, or in some cases as an add-on.
Yeah. And I think, again, shared decision making, some patients might even want that oral therapy before they choose to go on omalizumab. There are several options for patients even now, 2 primary oral therapies and then 1 injectable therapy.
Correct.
Are there any medications that are in the pipelines for urticaria? Because I do know that some patients don't respond to the antihistamines. They don't respond to omalizumab. Is there any research being done on other therapies?
There are some individuals that don't have the benefit, unfortunately, from antihistamines and from omalizumab. And so there are medications that are coming down the pipeline that are, at least in recent studies, have shown significant efficacy. The main one I can think of is this medicine called remibrutinib, which works in a different pathway. The benefit to this medicine is that it's also oral rather than an injectable medicine. So works for folks that maybe have some reservations in regards to using an injection medicine, or maybe have had side effects related to omalizumab, or maybe lack of efficacy.
And I also know that dupilumab, which we've talked about in other episodes and is used in multiple conditions, is also being looked at for its use in chronic spontaneous urticaria, but it hasn't been approved yet. So we do have some more options coming down the pipelines for patients with urticaria. Speaking about the quality of life issue with urticaria, do you do any kind of mental health screening? I know that's something that we've recently been talking about more and more with these patients, because we're realizing more and more what kind of an impact this can have on mental health.
The most difficult part about hives, especially spontaneous urticaria, is wrapping your mind around that they are just occurring, and the quality of life issues that occur with something that you can't really put your finger on what's causing it. Having discussions with my patients during the office visit, talking about how they are dealing with the stresses and how this is impacting their job or their sleep or day-to-day activities with taking the kids to school or picking up. So we have a very open and honest conversation about that. And then if there is a pretty significant impact, again, going back to the shared decision making, we talk about, are there resources in regards to just therapy that could be addressed. The good news is that with the benefit of omalizumab, majority of patients will have a significant improvement in their symptoms. And sometimes just treating the hives themselves, making them better, is what provides for that improvement in quality of life.
Other than medication, what do you do with your patients to help them with their symptoms?
For spontaneous urticaria, monitoring stress and just other factors that contribute, I think, is the best course of action. I get asked about foods and contribution from, say, low histamine diets or, say, pseudo-allergen-free diets. And so what pseudoallergens are basically non-allergic allergens, so foods that aren't mediated by an IgE response, or what I would call true food allergies. There haven't been head-to-head studies that have really looked at if food avoidance with these low histamine diets or avoidance of pseudoallergens really provides for improvement in chronic spontaneous urticaria. The main thing here is, again, that shared decision making. If our patients are interested in trying it, I think if it doesn't hurt them and it's not cost prohibitive, there's no harm in it. What I would like to see my patients not do is to avoid or have a very strict diet that gets in the way of their quality of life. So we want to be mindful of keeping a balance between avoidance of foods, low histamine diets, and monitoring their CSU, because my feeling is that it's not really being driven by a food process, and it's more so just occurring on its own rather than directly from a cause.
Yes, and we talked about this a lot the last episode, and I'm glad you're also reiterating it, is that food avoidance has not been shown in studies to help. And so if it adds to anxiety and stress, we know anxiety and stress can contribute to this disease. So it's just very, very important for patients to remember that and to understand that. But again, it is the patient's body or the person's body. And so we can't stop them from trying different diets, but we just want to make sure that we're giving them the best information possible so that they know that this likely will not help them and may just cause more anxiety and disruption to their quality of life.
I think from a patient perspective, I can see why someone wants to control their diet, because you get these hives which are spontaneous and you want to feel like you can have a handle on something. And I think that diet is the first thing that people go to because it's something very easy that you can control, but it can actually cause way more stress and probably make things worse.
Absolutely. It's just human nature, really, to think, oh, it must be the milk I drank or the wheat I ate that's causing these hives. And so a lot of my discussions with my patients is just kind of coming to the understanding that perhaps it's actually not related to those foods or those environmental triggers, and releasing and eating those foods and realizing that the hives just kind of occur on their own will sometimes actually decrease anxiety, because now they're able to kind of enjoy the foods that they've always loved and have that good quality of life.
Thank you so much, Dr. Gogate, for joining us and sharing your wisdom on how to treat CSU. Before we go, we always like to get last words from our interviewees. Is there anything that we didn't cover or that you would like patients to know?
Let me just close by saying thank you so much for the invitation. I have really enjoyed this conversation on this very important topic. And I guess I would end with that we have treatment for chronic spontaneous urticaria, and we're much further along than we were just a few years ago. And the pipeline for what's going to be available in a few years' time is just as bright. So go see your allergist, talk to your doctor. You don't have to suffer in silence.